Hello, hi, I'm Damiano Barone. I am a neurosurgeon with specialization in functional and peripheral nerve surgery. I trained in multiple institutions, starting my journey in Naples, and to then continue at the University of Cambridge in England, Mayo Clinic, and now practicing at Houston Methodist in Texas. Today, I plan to discuss about epilepsy surgery and the role of epilepsy surgery in drug-resistant epilepsy. When to refer a patient, what is the workup required for these patients, and some of the risks that needs to be discussed with people with epilepsy during the process of their treatment. Houston Methodist to be a level 4 comprehensive epilepsy program, one of the large in the country, and we benefit from key technologies that make our surgery very effective and very safe. And particularly all our surgery robotically driven. We do use the latest technology for imaging. We have a clinical 7 Tesla MRI, which allow us to pick up more lesions that cause epilepsy. We do perform both awake and sleep surgery, allowing us to perform safe surgical resection in people that might benefit from those. And we have an intracranial electrophysiology team made of neurologists and neurosurgeons, which are very well all together and able to really find and manage the difficult patient and find where the epilepsy is coming from. But why is important? Why epilepsy surgery is relevant? Well, a third of patients that suffer from epilepsy go on and develop drug-resistant epilepsy. After the first and the second medication are tried, trying a third medication seems not to be effective. And that is the time where a patient really should be referred to an epilepsy surgery center. A referral needs to be done in time to try to improve outcomes, and as we can see and we'll see during the course of this presentation, even save life. So in epilepsy, what happens nowadays is that the referrals are usually delayed because physicians trying more medication, and therefore patient has a delay in access to the epilepsy surgery program. However, this is a problem because this does not cost just a lack of reduced quality of life and outcome, but is a risk to the patient life. SUDEP, which stands for sudden unexpected death in epilepsy, is a condition when patients with epilepsy die from unexpected cause and is known to be much higher in patients that are surgical candidates for epilepsy. So potentially patient that the life could be saved if referred in time to an epilepsy surgery program. So what is drug-resistant epilepsy? Drug-resistant epilepsy is defined as the failure of trial of 2 medications which are properly chosen but don't work, and the patient continues to have seizures. Just this should just trigger the referral to an epilepsy surgery program. And what is epilepsy surgery? It's a surgical intervention that is aimed to remove and disconnect the cause of the epilepsy. This can be done by either removing completely or by modulating the network with the use of electrodes. And the goal is to either cure the epilepsy completely, so surgery freedom, seizure freedom, or to reduce the amount of medication that the patient is taking, with the aim to improve the memory and neurocognitive function of epilepsy patients. One thing that needs to be said, surgery is not the last resort. It's not patients have tried multiple medications, but it is part of the process that comes at that point where the patient has tried 2 medications but they still having seizures. There are other reasons to refer the patient, not only because of the 2 medications, but if there is any lesion in their MRI. If, for example, the patient has a cavernoma or a tumor that's causing epilepsy, despite the epilepsy being controlled by anti-epileptic medication, they should still be referred to epilepsy surgery program because potentially their epilepsy can be cured. There are not many things in medicine that have such high class evidence, and definitely not in surgery. But in epilepsy surgery, we have class 1 evidence and randomized controlled trial demonstrating that surgery is superior to best medical therapy at 12 months, and not just improving the seizure freedom, but also improving outcomes and quality of life. So what to do when a patient is indicated for referral to the epilepsy surgery center? It's important to very nicely describe the seizure history and the semiology, the comorbidity and the medication, attach to the referral the EEG and the brain MRI, and try to highlight some of the red flags, in particular if the patient has generalized tonic-clonic seizure overnight, any history of injuries, or if they are having any side effect from the anti-epileptic medication they are taking. But in practice, we're happy to see any patient that is deemed to be indicated for epilepsy surgery, and the use of method is we will repeat all the investigation required as part of our pre-surgical evaluation pathway. So this pathway is divided in two parts. There is a phase 1, which is the non-invasive, where we review our neurology team, we review the patient, we'll admit the patient to the hospital, and we'll conduct a video EEG monitoring where we'll be putting together the patient's symptoms. So the patient will have seizure while in the hospital, but at the same time we will collect, with the use of video and EEG, the electroencephalographic signal and their video. The reason why we do that is because we want to try to put together the semiology, so what the patient is presenting, for where the seizures are coming from. On the top of that, we will run advanced imaging, which, as I mentioned before, include a 7 Tesla MRI, which compared to standard 1.5 or 3 Tesla, are able to pick up more small micro lesions in the brain responsible for epilepsy. We'll also run other imaging, PET, SPECT, and MEG, which again help us identify which region of the brain might be responsible for epilepsy. Then we run tests to study the function of the brain, and that in preparation of potential surgical intervention. We will be studying using fMRI, DTI, WADA testing, if the memory is particularly on one side of the brain, where language is, and other aspects that are important to improve safety. And our neuropsychology team will assess tailored epilepsy tasks that help us again understanding the cognitive function of the patient and how they will be deteriorating over the course of the disease, and how they will be affected by the use of epilepsy surgery. And then phase 2 is the invasive part, is where we put electrodes inside the brain to try to map the more complex cases. Going in the specifics, we talk about the test that we will do in phase 1. What we're really trying to find in phase 1, what we're trying to find is concordance. Concordance means that what we see in the patient when he has a seizure, plus what we see in the electroencephalographic signal, plus what we see in the imaging, they're all pointing exactly in the same part of the brain. So let's say if the patient is presented with a classical temporal lobe epilepsy, and the patient has some signal change in the temporal lobe, and the EEG is pointing a signal in the temporal lobe, for us that is concordance, means that the patient has temporal lobe epilepsy and we can proceed to offer treatment. But often happens that epilepsy is more complex and it's not clear where it's coming from. Maybe the epilepsy looks that it's coming from the temporal lobe, but the EEG is maybe showing it's coming possibly from the frontal lobe, and the MRI might be completely normal. In that case, we say that we're not sure, there is no concordance, and that's when we proceed to phase 2. Phase 2 is the insertion of electrodes inside the skull, inside the brain. Historically was done as ECOG, subdural grids, which means electrodes over the surface of the brain. And with time, this has developed to SEG, which is electrodes inside the brain. Now, while electrode inside the brain sounds more invasive, it's actually safer and more minimally invasive, as this is done as a stab incision through the scalp and the skull, and the electrode is robotically and precisely inserted to a precise spot on the brain, depending on our hypothesis. For example, the patient from before, if we're not sure if it's coming from the temporal lobe or the frontal lobe, or it's coming from the right temporal or the left temporal, then we will be putting electrode in these places. And every electrode is an hypothesis. And then with those electrodes, we can precisely decipher the brain signal to tell us yes, the seizures are coming from, for example, the temporal lobe. After the ECG, in most circumstances, our hypothesis is verified, and then we'll have the source of the epilepsy. At that point, we meet with the patient and we discuss the different surgical options. If the epilepsy is coming from a part of the brain which is localized and can be safely taken away, then we will discuss with the patient about resective surgery. The epilepsy is localized in a part of the brain which is too dangerous to be removed, for example, the language area or the motor area, that might leave the patient without the ability to speak or with paralysis. Then in that case, we cannot offer resective surgery, and we'll be talking about neuromodulation. Another circumstance where we're discussing neuromodulation is after all our pre-surgical workout, we find out that the epilepsy is not coming from a single spot in the brain, but it's more generalized. It's coming from multiple spots. In that case, again, we cannot resect, but we can neuromodulate the network to still try to reduce the seizure burden. In terms of resection, the most common resection is the resection of the temporal lobe, temporal lobectomy, if the epilepsy is coming from the temporal lobe. Literature say that if a temporal lobectomy is performed in a well-selected patient, seizure freedom can be achieved up to 70-80% of the patient. With the reality, it means cure of the epilepsy rather than reduction or palliation or coverage as achieved with medication. Resection can also be done outside the temporal lobe. The seizure freedom rate is slightly lower, but seizure freedom is still possible. If the lesion is small enough and is localized in a deep region of the brain, we also have different technology we can use, which is laser. So I was talking about temporal lobe resection. Temporal lobe is a part of our brain that, depending on if it's the right or the left, is in charge of language, memory, vision, and some cognitive function. Removing the temporal lobe needs to be done in expert hands with the appropriate technology, reason being complication. For example, a left-sided temporal lobectomy has to be particularly wary about language. Most people have language on the left-hand side, and even people that are left-handed most time have language there. And language, while we can be mapped with some imaging and MRI before surgery, the only way to precisely know where the language part of the brain is by doing mapping intraoperatively. That's why we apply advanced electrophysiology technique, and we do this part of the operation awake, so we can exactly map which part of the temporal lobe is involved with language and leave that alone while we resect the remaining part which is affected by epilepsy. An epilepsy brain is not a normal brain. The part of the brain that is involved in epilepsy tends to be underperforming, and often by the time that the patient undergo epilepsy surgery, many of these functions have been taken over by other parts of the brain, and removing the part of brain that is involved in epilepsy does not cause deficit. If anything, improves the cognitive outcomes because of the reduction or the disappearance of the seizures. We talk about laser. Laser has been a great innovation because it allowed us to many operations that before required open resection to be done minimally invasive. Via a very small hole through the skin and the skull, we can put a laser fiber that goes deep, precisely inserted using neuronavigation strategies and robots to put the laser exactly in the spot where we know the epilepsy is coming from. The laser will burn that part of the brain, basically ablating and taking away the source of the epilepsy. Not every patient can have it. Some patients still require the open surgical procedure, but for any patient that can have it, this will be the first line of treatment. We talked about other type of surgery, in particular extratemporal and lesional. If the patient has a tumor, that tumor can be removed safely. If it's extratemporal, for example, it's a frontal lobe epilepsy or an occipital lobe epilepsy, can still go through the open resection. The rate of seizure freedom is slightly lower, but the outcome are overall still better than medical treatment. And then neuromodulation. Neuromodulation doesn't have the aim to cure epilepsy, but still can be really effective in reduction of the seizure burden and the reduction of medication. Medication are not risk-free. Medication have side effects, cause problem over time, and epilepsy itself, the total number of seizures, has a global impact on the cognitive function of the patient. The three neuromodulation strategy in epilepsy are vagus nerve stimulation, responsive neurostimulation therapy, and deep brain stimulation. Vagus nerve stimulation is the one that's been around the longest. We put as small electrodes in the neck, in the vagus nerve, and connect it through a small battery that sits in the chest like a pacemaker, and is being used for many years, is very safe, is a day procedure, and is a very good adjunctive treatment, reducing seizure in patients with global epilepsy. DBS and RNS are also excellent strategies, are slightly more invasive as they require electrodes in the brain, but they can go and act at the network and the point where the seizures are coming from, and the results has been extremely good. In particular, ANT has been proven in a trial, but we also have other targets in the brain that we know reduce epilepsy dramatically. The risk of epilepsy surgery are there. We're still talking about invasive strategy that might cause hemorrhage, infection, and neurological deficit. Saying that, in expert hands, this tends to be a very safe option. We use all the strategies, both surgically and technologically, to reduce a minimum. SCG, which is part of the diagnostic workup, does have a very low complication rate, around less 0.1 per electrode. What we were discussing before is SUDEP, and SUDEP really needs to be more advertised and recognized. This is not to scare patients, but to make them aware and make aware also medical professionals. SUDEP cannot be fully prevented, but definitely can be reduced if epilepsy surgery is used appropriately and early enough. So the key takeaway from this presentation should be that early referrals don't just improve outcome in terms of seizure freedom and quality of life, but literally save lives. So early referral is key. Thank you.